The next presentation will be given by Miranda Lomer. She is from London, United Kingdom. She is an expert in the dietary treatment of patients with gastrointestinal diseases. And we have invited her, and we are happy that she took the invitation to tell us about the dietary treatment of food intolerances. What is on the menu? What is still on the menu? What should be on the menu? Miranda, please go ahead.
Thank you very much for this kind invitation to talk to you about dietary treatment of food intolerance, what is still on the menu. My name is Miranda Lomer. I'm a consultant dietitian in gastroenterology at Guy's and St Thomas's in London and a reader in dietetics at King's College London. These are my conflicts of interest. So first of all, I wanted to just sort of put in the picture where food intolerance lies underneath the umbrella term of food hypersensitivity. So it's not related to food allergy, which is IgA mediated or non-IgE mediated. Food intolerance is a non-immunological issue. It's often associated with gastrointestinal symptoms. There may be pharmacological effects, things like salicylates, vasoactive amines, glutamates, and caffeine, which I'm not going to talk about today. I'm going to focus on the enzyme issues and transport defects. So the beta-galactosidase enzyme lactase is responsible for hydrolyzing lactose to glucose and galactose within the jejunum in the brush border. And there is a natural downregulation of lactase activity after weaning in humans. This is dependent on ethnicity, genetic predisposition, or it may be secondary to disease. So things like celiac disease, for example, where the brush border may be damaged, but it is reversible on adherence to dietary treatment. Lactose malabsorption, which is the presence of lactose within the colon, occurs in up to about 68% of the world population. So it's really quite high. And the lactose persistence is really this genetic mutation that we see that where certain populations have been able to tolerate lactose beyond weaning. But those who have lactose malabsorption, they may also have lactose intolerance. And this is where we see the presence of symptoms, particularly gastrointestinal symptoms, in relation to consumption of lactose. Lactose intolerance really only occurs when there's less than 50% of the lactase activity, the residual lactase activity within the jejunum. And with lactose intolerance, generally people can tolerate up to about 12 grams of lactose if it's spread across the day. So where do we find lactose in the diet? So lactose is found in dairy foods. So the high source is milk. So normal cow's milk would usually contain about 15 grams of lactose per 250 ml portion. Another high source is yogurt. You'll see that some cheeses are quite high as well. So those that have a very sort of fast processing, so things like ricotta and cottage cheese, whereas those cheeses that are take longer to mature, so things like cheddar, brie, have a very, very low level of lactose and are very well tolerated on a low lactose diet. There's often lots of confusion about how restrictive people have to be on a low lactose diet. And there is certainly no need for people to go completely dairy free if their symptoms are due to lactose intolerance. Just looking at the different types of milks. So if we look at the normal sort of cow's milk, semi-skimmed milk, whole milk, they have very similar levels of lactose. If you look at the ones down towards the bottom, the goat and the sheep, also quite similar levels. So some people swap from cow's milk to goat's milk or sheep's milk, thinking that they're going to improve their tolerance. And maybe there's some other effect going on there. Human milk is also a bit higher. And then if you look in the middle of this table, the dried skim milk is a very high source of lactose. And this is what's often used in food processing. What about suitable alternatives to milk if someone wants to take milk out of their diet? So as I said, they can usually tolerate 12 grams across the day. So we say up to 4 grams at each sitting is usually well tolerated. So perhaps 50 mils of milk in a cup of tea or coffee would be absolutely fine. They can also use lactose-free milk where the lactose has been treated with lactase, or they can choose plant-based milk alternatives. So things like soy milk, rice milk, oat milks, nut milks as well, quinoa, hemp, and coconut milk. What's important is when people choose these milks is that they choose ones that are supplemented with calcium, so they're not limiting their calcium intake. So what about other enzymes? So the human gut has a lack of enzymes to break down glycosidic bonds, so things like fructans. And fructan absorption, which is a type of carbohydrate in the diet, is actually quite low in the human gut. And we find that absorption is less than 5%. So there's a lot of fructan available in the colon for bacterial fermentation by the microbiota. And the type of fructans that we have in the diet are things like inulin, oligofructose, and fructooligosaccharides. Fructans occur naturally in the diet, naturally as storage carbohydrates in some cereals, things like wheat and vegetables, so things like artichoke, garlic, and onion, or they may be added to food for their prebiotic properties. What's interesting about wheat is that fructan content of wheat is only about 1%. However, because we consume wheat in such large quantities, it actually provides about 2/3 of the fructan intake to the normal Western diet. Another enzyme that's lacking in the human gut is alpha-galactosidase, and this is responsible for breaking down alpha-galactooligosaccharides, which are another type of FODMAP, just like the fructans I mentioned earlier. Again, these end up in the colon and are available for bacterial fermentation. The two main ones in the diet that we have are raffinose and stachyose, and common dietary sources would be things like legumes and pulses, some grains, and also some nuts, things like pistachios and cashew nuts. And then moving on to the transport defects, so things like fructose. So we have a limit to the amount of fructose that we can absorb within the gut. There are two transport systems that are responsible for fructose absorption. One is the GLUT2, which is a co-transport with glucose, and the other is GLUT5, which is independent fructose absorption. And this is done through carrier-mediated facilitative diffusion. There are other GLUT transport systems, but these are less well researched. So it's the free fructose that can lead to signs of fructose intolerance. And what can happen with this free fructose is you get an increase in the small intestinal water, and that increases gut motility. And then you end up with fructose in the colon, which can lead to fermentation, other symptoms in people with intolerance. Sources of fructose include things like honey, certain fruit, things like mango. These are sort of more issues related to lots of high fruit or high fruit juice type diets. Sugar alcohol, so things like sorbitol, mannitol, and xylitol. There are also issues with transport for these particular types of polyols. The absorption is a passive absorption along the small intestine, and this is very much dependent on the molecular size of the polyol, the intestinal pore size, and the small intestinal transit time, and the presence of GI disease. Sources of sorbitol would be things like apricots and peaches and other stone fruit in particular. Mannitol is found in mushrooms and cauliflower, so more sort of vegetable origin. And then things like xylitol. This is an artificial polyol that's added to things like sugar-free chewing gum, sugar-free chocolate, Other polyols can also be added as a food additive to add sweetness to products as well. So thinking about all of these different enzyme and transport defects, what about the actual patient that we deal with? So this study by Magnus Simnum's group in 2013 showed that 84% of adults with irritable bowel syndrome report gut symptoms related to at least one food. And that's shown on the right-hand side here. On the left-hand side, we can see the foods that are related to those that are incompletely absorbed carbohydrates. And 70% of patients reported problems with incompletely absorbed carbohydrates. Interestingly, almost 50% of those were due to dairy products. So the milk and the lactose issue came in here. And then the next in the list is the beans and lentils. So that's the galacto-oligosaccharides again. And then looking down, there's a lot of these FODMAP type foods that do cause problems for patients. So what about diagnosis of food intolerance? So we do have breath tests, and the lactose breath test has been used for many years, and it is a very, very good tool for assessing lactose malabsorption. And it has very good acceptability in terms of sensitivity and specificity. However, the other three types of carbohydrates that have been used for breath testing, things like fructose, sorbitol, and mannitol, there's very poor correlation between the intolerance of malabsorption and also the tests lack reproducibility. So we don't really use these ones anymore for diagnosis of food intolerance. So what do we use? Traditionally, the gold standard for diagnosis has been food exclusion and re-challenge. So what that means is that you have dietary exclusion until symptom resolution, which is usually around 4 weeks, and then dietary re-challenge to induce symptoms, increasing the dose of that particular food or foods to assess the tolerance threshold, and then sort of monitoring that and reintroducing the foods to personal tolerance thresholds. So what does that mean? How can we improve tolerance? So things like mixed meals can improve tolerance and lengthen transit time. Cereals and increased energy content can delay gastric emptying, so that may be something else to think about. And food temperature, so very hot and very cold food can affect transit and tolerance, so it may be that avoiding those sorts of things are quite important as well. So in dietetic practice, we use the British Dietetic Association guidelines from 2016 for IBS management. So the first line when we look at food intolerance, especially to milk and lactose, if we find that exclusion of that is not particularly helpful, then we may be looking at second line treatment, which is the low FODMAP diet. So just to sort of recap, when do we restrict the diet and to what extent might we be restricting it? So we might be thinking, first of all, reported problem foods. So trying to identify what the problem foods might actually be. What are the symptoms associated with those foods? What's the current diet and the eating pattern like? What are the results of breath tests? Are they helpful? And then thinking about what patients might be able to comply with, what's going to be appropriate. And of course, patient choice is really important in all of this. So in conclusion, I'd just like to say that food intolerance is extremely common, and the GI symptoms are particularly problematic. Reduction or lack of enzymes, so things like lactase, the enzymes to break down fructones and alpha-galacto-oligosaccharides. We've talked about the transport defects for fructose and for the polyols. We've talked about diagnosis, so using breath tests, which is really helpful for lactose, but not for the other carbohydrates. and how we use food exclusion diets and reintroduction diets, and how we might manage that better in the long term in terms of restricting and reintroducing to tolerance thresholds, thinking about mixed meals, gastric emptying, and transit time. Thank you very much for listening. I'd just like to acknowledge the research and clinical teams that I work with, and the support from various funding organisations. Thank you.